Before we jump into this episode, I want to remind you that while Caitlin and Sophia are dietitians, we're not your dietitians. This means the information shared in the Food Freedom Fertility podcast is intended to entertain, educate, and inform. It is not a substitute for medical care. This information is not intended to diagnose, manage, or treat disease. Always consult with your doctor before making any changes.
Welcome to another episode of Food, Freedom, and Fertility. We are smiling today, looking at each other because we have basically our favorite guest in the house, Dr. Gary. He is a repeat guest who literally shows up with wisdom, grace, and a great sense of humor and brings a level of expertise to a fertility show that Sophia and I are not trained in. So
No, we're not surgeons, guys.
We're always thrilled to have Dr. Gary.
Let me blow your
here.
mind with this piece of information. Caitlin and I aren't surgeons.
Yeah. Nor do you want us in the surgical room at all. So here we have Dr. Gary. Dr. Gary, welcome. Where are you in the world today?
Hello, ladies. Thank you so much for having me on again. It's a pleasure as always, and I'm glad you guys are all doing well and looking great. Currently, I'm situated in Las Vegas, Nevada, and it's really, really hot. I appreciate the introduction. I almost thought you were going to say I'm a repeat offender, not a repeat guest.
No.
But here I am.
You've yet to offend us. We're waiting.
I've tried, believe me.
That's true. But you just don't know the crowd you're with.
All right. Well, yeah, thank you again. I'm very excited to be here and I hope to impart any kind of information and guidance that I can on your listeners.
Yeah, I have some questions that I think we're just kind of doing a rapid fire, things we've been thinking about, things Dr. Gary knows. I had a question from a client yesterday that I was like, this will be perfect for our episode tomorrow. And this was the question. I ovulate frequently. I have a husband that has a normal semen analysis. Why is the first step my reproductive medicine practice is offering me is medication to help me ovulate? Like, I am already doing that. Why are they pushing Letrozole as my first option? And I was like, Dr. Gary knows the science behind why that is very often a first option. So what do you have to say?
Well, to answer your question, I would have to presume a bunch of things.
Right.
So we were going to assume that the fallopian tubes are open. We're going to presume that there isn't a diagnosis of endometriosis. The rest of the history or any potential issues have been addressed. And if everything else has been addressed normal, and there has been a significant time for that the couple has been trying, for example, let's say a year and a half, and they haven't gotten pregnant. If everything else has been addressed, medication does increase the probability of conception because it allows ovulation of multiple eggs. So medication allows for superovulation, and in some studies that's been that's helped couples conceive, all else things being equal. So it's not the wrong approach. And it's probably the initial approach in the vast majority of cases, depending on obviously some other things that we don't know based on the history. But certainly a reasonable thing to do if we correct for everything else and address everything else. The biggest thing that I want to say as a follow-up answer to this question is all of that should be based on a foundation of good health. So all medical treatment should be based on a foundation of good health. So excellent diet, activity levels, certain supplements that we recommend, and any kind of medical intervention is a lot more effective if it's done in context and on a foundation of good health.
Yeah, absolutely.
I want to take a minute out of this episode and talk to you about our partner, Fertility Cloud. We decided to partner with Fertility Cloud this season because we have worked with women all over the nation, and we have heard the same issues arise again and again. My doctor can't see me for another 8 weeks. I had to wait 3 months to see a specialist, and even then, they didn't really tell me anything. Or there's no one in my small town that knows anything about my situation or can help me. And that's so common because unless you live in a major metropolitan area or a place that has grand medical universities, and honestly, sometimes even then it's still an issue, it's really hard to find fertility specialists who can give you tailored, customized help for your unique fertility situation. And that, my friend, is exactly what Fertility Cloud does for you. They offer everything you need, but right in your home because it's fully online. Another perk is they often have same day or next day appointments, so no waiting weeks and weeks and weeks in order to be seen by someone. And my favorite thing of all, really the pièce de résistance and the reason we are partnered with Fertility Cloud for this season, is they have a love and a passion for helping families grow. It is why they do what they do. It is why they wake up in the morning. It is why they have this world-class staff who cannot wait to step in and help you along your journey. So if this sounds like what you have been dreaming of, click the link in our show notes and go to fertilitycloud.com for $50 off your first visit.
I have a question on top of this question. So let's say that this, we're using this hypothetical person. We can just use this as a launching board. So she's ovulating regularly. Her husband's had a semen analysis. Let's say those are the only two things that have been done. She's had basic metabolic panel. She's been confirmed to be ovulating. We're sure that there aren't any glaring issues, but maybe that's the only testing that's been done. Typical, whatever your usual blood tests that someone does when they start this process. And so we've confirmed ovulation, maybe with a progesterone test or maybe with a wand ultrasound, and we've had a normal semen analysis. That's the only testing done thus far. What else do you like to look for? What other testing maybe should be done? What are the criteria that you use before you decide a treatment like letrozole would be appropriate? You mentioned maybe like tubes being open, endometriosis evaluation. What do you look for before you reach for these medications?
So let's talk about the standard and the recommended fertility evaluation. So what we really need to do is interrogate the entire reproductive system in the male and the female before we start treatment, because we can certainly do empiric treatment, and in some people that's appropriate, but we really want to target whatever issue that the particular heterosexual couple is having. So the first thing we want to do is certainly take a history and see how long the infertility has been going on. Things that have last a lot longer tend to have a lot more problems than things that with a short duration of infertility. So we want, first thing, you're absolutely right, we want to make sure that the female is ovulating. The most common problem that we would encounter, if we were to encounter a problem, tends to be a male problem. So a sperm analysis is probably the most important test to do. The other thing we always want to evaluate and is the ovarian reserve, which is kind of the quantity of the remaining follicles. And then we can evaluate that with ultrasound. We can evaluate with blood work. There's multiple blood tests that we can use to gauge what that is. My preference for a comprehensive evaluation is typically to do both and then marry them up, looking at what the images show, the follicle counts in combination with the blood tests. That particular test isn't necessarily going to change what we initially do, but it may change the strategic approach if our initial interventions aren't effective. So, for example, how quickly do we transition to something more invasive like IVF if that's an acceptable option for that particular patient? We want to make sure that the fallopian tubes are open, which are the conduits between the uterus and the ovary. These organs are responsible for picking the egg up, allowing the egg and the sperm to meet, facilitate fertilization, and then move the fertilized egg into the uterus. Now, that tests for fallopian tube patency. We have X-rays, we have ultrasounds. What they allow us to do is to document whether or not they're open, whether or not they're blocked. What they don't allow us to do is test tubal function. Tubes are functional organs. They have little micro hairs in there called cilia, and that's what actually does the movement of the sperm and the eggs.
So it's not just like a smoothie straw. There's like stuff happening in there.
It's all the time. So it secretes fluid. It has cells, kind of like a trachea, where it moves things back and forth. And anything
Amazing.
that can block the tube can actually damage those hairs and those cells that call the functional capacity of the tube. But we don't necessarily have
Treatment
a test.
modality.
Well, we have a treatment. We don't have a test for tubal function, so we can tell you if the tubes are open. So, for example, let's presume that a particular patient had multiple episodes of pelvic inflammatory disease, and we do an HSG or an ultrasound to document tubal patency, and they're open. But they really haven't gotten pregnant over the course of multiple years, and everything else is normal, and the tubes are shown to be open. We can probably presume that the problem is tubal because of whatever damage was done to the tube, and the function of the tube is inappropriate, despite the fact that they're open. So, there's a lot more to it just in looking at the pictures. We do need to elicit a lot of specific information from a couple to really get to a good diagnosis. So we talked about ovulation, we talked about sperm, we talked about tubes. We want to take a look at the uterus. The wall of the uterus sometimes can have things like adenomyosis, which is endometriosis within the uterus. We want to make sure that the uterine cavity is normal. There isn't any kind of polyps, adhesions from any potential prior surgery, or things like that. So it is a comprehensive evaluation. We do get a lot of information simply from talking with the patient. And talking with the patient, we can triage a lot of things for specific testing. And so in some people, they don't really want to do some invasive testing, or they live really far away from having an ability to do that invasive testing. So having a conversation with the patient, understanding what the risk factors are for certain issues, we can certainly come up with the right
individualize a plan
exactly
based on
individualize a plan.
their specific goals and needs or uniqueness.
Exactly right. But the comprehensive evaluation, and typically what most people want, and we always recommend, is looking at comprehensively at the male and the female reproductive system.
Mm-hmm. We are so glad you're enjoying this episode, and we want to take a brief moment to talk about one of our sponsors, Fullwell. Fullwell is not only a reproductive nutrition supplement company created and formulated by a registered dietitian, but they are a company that has the highest quality standards. They use the most bioavailable ingredients in the right amounts to ensure that you're getting the most out of your supplement. And let me tell you about one specific supplement, the Fertility Booster. The Fertility Booster is a combination of adaptogenic herbs and powerful antioxidants. Oxidative stress is something that occurs in every single body, and when it's accumulated, it can deplete antioxidants. Upping the antioxidants in the body by turning on the antioxidant protection system through food and supplementation is one way to support the body's free radical defenses and better support fertility overall. Oxidative stress impacts all humans, and this is one thing I love about the Fertility Booster. It helps supercharge both egg and sperm quality. You've heard about stress and how it can impact so many things in our body, and how so many people just say, hey, just relax and you'll get pregnant. Well, ashwagandha is actually an adaptogenic herb, and it can help reduce cortisol levels and increase sexual function. So the next time someone tells you to just relax, you can say, hey, no, I don't need to just relax. I'm taking the Fertility Booster by Fullwell and supporting myself in this way. When we talk about powerful antioxidants, one of them that is the king of the show is coenzyme Q10. In its reduced form, it functions as an antioxidant in cell membranes and lipoproteins, helping to optimize fertility. And the queen of the show, in my opinion, N-acetylcysteine. It's a supplement form of cysteine, a semi-essential amino acid that benefits fertility via its role as a precursor to glutathione. It can also support healthy cervical mucus. So, next time you're ordering your Fullwell Fertility Prenatal, make sure that you grab a hold of their Fertility Booster so you and your partner can get a healthy dose of these antioxidants and stress support. Use the code FFF20 at checkout to get 20% off your first order. And now, back to our show. It's interesting, I can fill in a little bit of the dots here for this particular case study, we'll call it. It's a dietitian who just because she's a dietitian doesn't make her eat well, but has a fairly well-balanced diet, I would say. Has been trying for a year, no luck. We talked about sex timing and travel plans and like, were you actually in the same location in fertile windows? Had a reasonable understanding of fertile windows and could say like 9 or 10 cycles we did try within the fertile window. His semen analysis was great, except for the morphology was only 1%. So that was like one piece of the puzzle. They did an HSG. Her tubes were open and patent, and no other things that stood out. And lab work was pretty minimal, in my opinion. They looked at her AMH and her FSH, and they looked at some autoimmune things, but that was really it. And at the end of the day, she walked away with an unexplained infertility diagnosis and an option to either jump straight to IUI or take letrozole in the meantime. And her, she left really baffled, like, is it really unexplained or is morphology the issue? Is it really unexplained if you're telling me I should take this medicine that's going to help me ovulate? Now, the one thing that's kind of interesting in her case was what she called the female athlete triad, and this idea of not having a cycle for a good portion of her teen years because she was a college athlete and a high school athlete. And that was just kind of part of her story. But she has a normal, regular cycle that she described as being 25 days average. So they're looking at it from the outside in, you're like, well, they're telling me it's unexplained. They're telling me these are the next steps, but I don't even really know what to do. And she left with the question, which her doctor kind of didn't, I don't know if she didn't ask it or he wasn't able to help her with, was like, why would letrozole even work for me? Why would it even be the first thing to try in a scenario like this? Isn't the morphology something we should look at?
Yeah, well, let's kind of break this down a little bit further. Maybe we can tease things out that hopefully will be helpful. So how old is the couple?
Late 20s.
Late 20s. All right. So morphology, let's look at the male aspect a little bit. So there is the total numbers of sperm, proportions of sperm. So sometimes if everything else is normal, but morphology is the proportion of normally appearing sperm is low, but in the ejaculate, there's so many millions of sperm that the proportion is irrelevant because the absolute number of normal appearing sperm is adequate. And it's not that the 1% isn't really clinically relevant.
Yeah, because like 1% of 200 million
is different than 1% of 2
different
million.
Yeah, exactly.
1% of 20 million. Exactly. So that's something to further interrogate. If there is 800 million sperm in the ejaculate and 1% is normal, theoretically, that's a normal sperm analysis. Okay. Now, if it's 20 million for 2 mLs, the proportion is going to be low, and then the absolute number is going to be low. So that's something to evaluate as well. And I think that if it's on the lower end of normal, it's reasonable to add the insemination to kind of get the sperm closer to where it needs to be, or a higher proportion of normal sperm closer that it needs to be. But the insemination itself, statistically speaking, based on the available literature, isn't going to be effective. The insemination is going to be, it's a supplement to superovulation or ovulation induction or ovarian stimulation, depending on the term you want to use. Because what really we want to do is get a slightly higher number of eggs than normal and a slightly higher proportion and number of sperm than normal closer together in the tube. So letrozole is going to help her ovulate multiple eggs. The IUI is going to help
bring things closer to one another.
Exactly. More normal process sperm closer where it needs to be. And the two interventions together is going to increase the probability of conception for that particular cycle. It's not going to increase it by 50%. It's not going to increase it by 25%, but maybe a 10 to 15% compared to where they are without intervention. So, yeah. The other thing is that's the sperm. The other thing, you said she had amenorrhea when she was an athlete, and then as her activity levels decreased and probably body fat percentage increased, she resumed ovulation. And then you said about 25. So it's important to figure out how long her follicular phase is, how long her luteal phase is, because if her luteal phase
That's what I was going to say. Ding, ding, Dr. Gary. My
slightly
ear is
shorter,
always training for the luteal phase. I'm so,
yeah,
yeah.
then it may be some ovulatory dysfunction. She may be releasing an egg, but the environment around where the egg is being released may be suboptimal for the optimal chance of conception. So
Mhm.
all of those things, like I said, we can figure out just by talking to, without any, maybe potentially even doing some blood tests.
Mhm.
So, and letrozole may help because one, may potentially ovulate multiple eggs. So more corpus luteum, more progesterone, may address that issue. Some women who were athletes have a higher probability of potentially having endometriosis. So if her periods are really painful, that may be an issue as well. So lots of things to address outside of just the very basics.
Yeah.
But keep in mind, because of how the fertility space has evolved, our treatments tend to be fairly successful. So a lot of times people just kind of default to empiric treatments without doing that specific interrogation and diagnostic.
We're taking a break from this episode to talk to you about one of our wonderful sponsors called NutriSense. So this isn't just another health trend. This is a program that helps everyone take control of their health and fertility by making lasting changes based on their unique needs. NutriSense is loved by over 100,000 members, and it offers a unique combination of expert nutritionist support from credentialed experts with continuous glucose monitoring data insights. So it's science plus a human touch, and it offers one-on-one support from the expert nutritionist team at NutriSense. So basically what NutriSense does is it gives you the support you need along with the data that you're getting from a continuous glucose monitor. Combining those two together with NutriSense offers you a science-backed way to take control of your health unlike anything else out there. It's access to the continuous glucose monitor as well as guidance from a nutritionist so that you can interpret this data and turn it into lasting results in your body. If you've listened to this podcast for more than 90 seconds, you know that we really don't believe in like a one-size-fits-all nutrition plan, and that things really need to be tailored to an individual for their personal health and fertility goals in order to succeed. And that's really what NutriSense offers. If this sounds like something you're interested in, which, P.S., you should be interested in this, head over to nutrisense.io/FFF and use the code FFF50 to get $50 off your first month with NutriSense.
Just to fill in, I mean, since we're here and we're talking about it, 34 million sperm concentration. And that is exactly what we talked about on it. Her ovulation data around using ovulation predictor kits was estimating that she ovulated like day 15 or 16. So I was like, girl, you got a short luteal phase and we know there's a progesterone issue. So like there's a piece there, obviously. And it sounds like she and her husband fall in this category of not just female or not just male, a little bit of both. And what she kept saying in the conversation, which I just think a lot of people will relate to, is it's like there wasn't one thing that was like, oh, this is the problem, or this is the problem, or this is from everything's kind of like in the gray. And her frustration was like, what do you do when the information's in the gray? And as we were talking, I was like, well, but I don't feel like the information's in the gray. So it may be that you're talking to somebody that doesn't see the black and whiteness of it. And so it's just interesting hearing you bring up your point of view, Dr. Gary, because there are things to address there, right? And it isn't so gray necessarily, even if we do have treatments that can help.
Right. And so the other thing that I think it's important to address is what are the priorities of this particular individual? Some people they don't necessarily want to get into the weeds of the diagnostics, and they really just want a very expedited treatment that's going to be the most effective. And they're going to come in and we give them this information and they're say, great, let me do IVF because I want to get pregnant yesterday, and I don't really care if we're going to do this particular treatment, hypothetically speaking. Some people aren't like that, and some people's priority is to correct whatever problem and maybe be as natural as possible. So that's also an important thing to ascertain, is what are the priorities and the values of the particular individual, and which avenue then we would then treat them with.
So I have a question then, going back to this letrozole treatment
Mm-hmm.
being the first line that this doctor's offering.
Mm-hmm.
And you kind of gave some qualifiers of like when you would use this treatment. When wouldn't you? Like, what would be a scenario to where you are like, I don't know, I don't want to give you this medication.
Well, I mean, there's tons of hypothetical and actual
I just
situations
bring this,
when,
let
yeah.
me clarify it a little bit then. It
Mm-hmm.
seems like, in my experience, and perhaps this gal is experiencing something similar. I don't know if Caitlin, you've sort of seen this too. Letrozole and Clomid seem to be given out, and I've actually had patients
Mm-hmm.
given this, and there was underlying disease that was never evaluated, and it's truly progressed the disease, and they ended up either very ill or having complications down the road. And then once the original problem was addressed, they were able to get pregnant without medication.
Mm-hmm.
So, what do you look for to say this maybe wouldn't, we need to do other things first, or this maybe you're not a candidate for this medication at this time?
Yeah, so keep in mind, so everything that we do, we try to increase the probability of conception compared to and everyone's baseline is going to be a little bit different. And so if based on our evaluation, for example, medical intervention without anything else is not going to change those statistics or improve that prognosis, then that particular couple or that particular individual is not a good candidate. Now, for example, if the tubes are blocked or there are significant sperm abnormalities, then the female at that juncture is not a good candidate for letrozole. But for example, if they have tubal surgery and the tubes are then made patent and then they try and then they don't get pregnant and everything is normal, then for example, they may be a candidate for it. Now, for men, a lot of times their initial sperm analysis is abnormal, and sometimes they go on medications like Clomid to improve their sperm quality because, for example, they don't want to do IVF or insemination is not the right, or their parameters aren't high enough for insemination to be successful. Again, all other things being equal and addressed. And then they get to a point where their sperm quality and quantity is reasonable, but they still haven't gotten pregnant. Then, for example, we can provide superovulation or ovarian stimulation for the female, again, to potentially increase the number of ovulated eggs to improve the probability of conception. So every case is going to be a little bit unique. I would say that if you want generalities with regards to who are not good candidates for ovulation induction or superovulation, it's going to be women who are of significantly advanced reproductive age with a decreased ovarian reserve, sperm abnormalities that are not conducive to a spontaneous conception, fallopian tube abnormalities, like really bad uterine cavity issues where there's fibroids or real polyps in the cavity that haven't been addressed. Those are like the main general categories.
Super helpful. Love that. Dr. Gary, when people are kind of navigating a scenario like this, where it's like this or that, and there isn't a compelling, like, belief system or core value of someone saying, like, I would approach it typically like, hey, I want the more natural approach. But not everybody's that way. If there isn't something that's kind of pushing you one way or another way as a clinician, and as you're educating clients or patients in, these are the scenarios, when do you get to a point where you're like, hey, if this were me, this is the route I would take? Like, do you as a clinician feel like you have that type of a conversation? Because I always love when I go to the doctor with my dad and his doctor says, hey, if this was my dad, I would A, B, C, and D. Do you put yourself in the patient's shoes in that way?
All the time. My spouse went through IVF, and so there is always not always, but there's definitely chances or instances where I say, if I was talking to my wife at this point, I would recommend X, Y, or Z for these particular reasons. And we actually did X, Y, or Z for these particular reasons, and we were successful.
There's such big life decisions people are navigating.
And so the other way I approach it is that I see sometimes 10, 20, 30 people a day. And for us, I mean, I try to treat everyone as an individual. But to be honest, I mean, it's an academic endeavor. But for them, it's the most important thing that they do all day. It's probably the most important thing that they do all year, if not
Their whole
that
life.
decade or even in their life. So we try to approach it from that perspective.
Mm-hmm. Yeah, with respect and honor to what this person's actually going through. I went to a memorial service before we were recording today, and the officiant was our pastor at our church, and he said, I just officiated a wedding this past weekend, and there's just like this beautiful love between a brand new couple. And now I'm looking at you, Dory, whose husband, Tom, just died after a lifetime of service in the Air Force and after years of going to church and raising a family. And there's like this beautiful young love this new couple's experiencing. And then I'm looking at the product of somebody who just lost their spouse, that they lived their vows and carried that to the end, in sickness and in health till death parted you. And it really honestly made me reflect on the work that we do, in that, like, we come into people's lives at this crux of something that they so desperately want, and is to them not just a child, but like a symbol of their love as a couple and a symbol of so many different things. And it's like when a couple first starts trying to conceive, it's all the, like, let's go have great sex, and you think you're going to get pregnant, and then they end up in your office, Dr. Gary, and it's the story that they never expected they would be living. And so much gets tested in that, to deal with it with the respect that you just shared of, like, this is the most important thing that they're doing. I love to hear that, because it really is like the work that you're in, that we're impacting people's lives and generations.
Yeah. And not only are you impacting people's lives, I think you're impacting one of the most important conditions of the human existence, right? So reproduction, having children, people would argue it's the most important thing you do in your entire life.
It's what everything, I point this out to people all the time too, because it's like, it's not just the human existence. This is what every organism around you is doing. That tree outside your window is trying to reproduce. The grass in your lawn is trying to reproduce. The bacteria under your fingernails is trying to reproduce. It's one, remember back in like elementary school biology, like reproduction is one of the qualifiers of, do we consider this piece of matter, is this creature alive or not? And ability to reproduce is one of the factors. It's core to being alive. And when it goes awry, like Caitlin just said, everybody dreams they're going to fall in love and have all this hot sex and just have their beautiful babies whenever they want them. And when that dream is shattered, it cuts to the core of what it means to even be alive for a lot of people.
So excited to tell you that the PCOS app is sponsoring this podcast episode. The PCOS app is a one-stop shop for all things PCOS. It's also your meal guide and inspo all in one. If you love listening to me on this podcast and you feel like, hey, I want Caitlin to be in my ear every day encouraging me about how to manage my PCOS, then you have to go download the PCOS app. We have curated articles to answer questions that you have about PCOS. There are short snippets in the PCOS Answers podcast exclusive to the PCOS app. We also have recipes where I not only give you the recipe, but teach you within the recipe itself what I have done to make it more blood sugar and hormone supporting, so that you can take your own recipes and make them more PCOS friendly. If you've been looking for the Google of all things PCOS, with the filter of compassion and expertise that you get from Caitlin Johnson, RD, then you have found it in the PCOS app. Head to your Android or Apple store today, download it, and let's hang out.
That's exactly right. So it's a tremendous privilege to be in a position to help people reproduce and complete their families. So we do take it seriously, and we want to give it the due diligence for every person that seeks our assistance. So that's why when we talk about things, that's why I'm very detail oriented.
I love it. Well, I know you've got a waiting room full of patients waiting for you, of course. Who wouldn't be in Dr. Gary's waiting room?
I've been texted on silent.
Yeah, and if you want to be in Dr. Gary's waiting room, listen to the ads in this very episode where we talk about how to work with Fertility Cloud, because you can do it too. If you love what you hear, Dr. Gary or physicians trained by him, working with him, selected by him, are available online as well. So thank you for your time today, Dr. Gary. We want to be respectful of that. I know you had a hard stop. So
well, thank you
thanks
so
for
much.
coming on.
Always a pleasure of being on your podcast. It's always interesting how the conversation progresses, and we got a little bit philosophical today, which I really enjoy as well. So again, thank you, ladies, and I hope you guys have a good
You're a
Labor
real
Day
one, Dr.
weekend.
Gary. Thanks for coming on. And listener, thank you for listening. Remember, if you liked this episode, if you think it could help someone, anyone, please review, rate, subscribe, share. You know what to do. It really helps other people find us, because right now there are other families out there praying to God to please bring them a baby. And we want to be there for them. That's why we're doing this. So use those tools, and we will see you in our next episode. Thanks for listening.
Hey, it's Sophia. If you love the show and want to continue your health and fertility journey using our resources, head on over to foodfreedomfertility.com for show notes, links to products and services, information about our guests, and our newsletter. Again, that's foodfreedomfertility.com. Thanks for listening.